separate my side. I don't believe it's fair. Slitting my brother's soul, I am bound. A hundred lost to the photograph. Thought it up and brought up the past. Once you know you can never go back. Mm. Mm.
Hey, hello, Manuel. Are you there, Manuel? It doesn't matter. Okay, we start in 20 minutes, guys. Can everybody hear me? Anybody hear me? Oh, that tells me I'm on my YouTube. I'm on my YouTube, which I should not be. Okay. Okay. Okay, can you hear this? Can you hear this? Oh, Ben's here. Great. Hello, Ben.
Hello, John.
How you
Hi.
doing? How you doing?
Fine.
Okay, let me get off the pin here. Yeah, let me just explain what I do right now is I essentially go to the major neurosurgery groups and post the live feed because you can share the feed like we're talking now. It'll be on that feed so that when people see it, it's a running video. And then we send to LinkedIn and WhatsApp, of course, is I don't know if you guys use that a lot in China. WhatsApp?
No,
No? Okay.
no.
They do in the Middle East, especially here in India.
Mhm, mhm, mhm.
They like WhatsApp. So
Yeah. I know.
so you've been busy. How many bypasses today?
Today, three bypass and three interventional treatment.
Oh, three other procedures.
Yeah.
That's a slow day, huh? Okay, I'll be back.
Okay.
Okay.
So, can you send some, John?
Yeah.
Can you send some introduce for Dr. Ip?
I
Yeah.
yeah, I sent him an invitation. He still says he doesn't have it. Okay. Let me Yuha may come. I'm not sure.
Okay.
Yeah, I sent him a couple of links. You know, Zoom is getting it together. They give you a long link because of security problems,
Mhm.
and there's a program you can cut the link down,
Ah.
but sometimes it degrades, it breaks apart. So some people can't get in. They say the link doesn't work, but not too often. But Zoom, I'm sure, will address that. They're still new, relatively new, and all these people, trying to hack it. So they'll shorten up their URL, make it easier for me. Anyways, it's good to have you, Ben. I'll be back.
Okay.
Hey,
Hey, John.
you're at the farm still, huh?
Yeah, I'm at my farm. So I'll be moving in 3 days out of my farm to the Karad, and
Oh,
then
good.
we expect to have a good time from Karad.
Okay, Ben is here. Ben,
Hi. Hi.
Hey, Bin.
Hi.
So good to see you, man.
Yeah.
It's an honor to have you. Yuha is also joining, I think. Yuha
Okay.
told me he's coming too.
Hello, Professor Cherian.
Hey, Manuel. Good to see you.
hello, Mohammed.
Hi, John. How are you?
You know
How
Ike,
are you,
right?
John?
You know
How are you,
Ike,
Professor
See
V?
you all.
Hey, so good.
And
Hey,
Mohammed, you know
good to see
Ben.
you all.
You know Ben.
Yeah.
Yeah.
Hi, sir. Hi, sir. How are you, sir?
Fine.
I'm
Thank
doing
you.
absolutely fine.
Yeah,
How
we
are
met
you?
several.
Okay,
Yeah.
fine, sir.
Oh, good. I'm not Trung. You're here from Vietnam. Hi, welcome, Trung.
Hi. Hi, Professor Bin.
Haven't
Hi.
seen you for a while.
Hi, Cherian.
Oh my God, we have the artists coming in, Morlix.
Yes, I met them on Beijing last year.
I'm glad you're here.
When do we start?
10 minutes, Ike.
Right. So I'm all set.
Yep, we're all set. And Warlix, good day, Warlix.
Hi, Professor. Hi, John. Hi, Dr. I.
How you doing?
Hey,
Put
Warlix.
your camera working, Warlix?
Yeah, I'm good. I'm good.
Okay. I want everyone
Good
to
to
meet
see
the
you,
artists.
Boralax.
To see you too, professors.
And you know,
Boralax has
Dr.
been doing a fantastic job for us with design and everything. So,
I know she's her color. I love the color you use. It's different.
yeah, she's really talented. She's very talented, I must say.
Well, it brings attention. It definitely brings attention.
Oh, like different actually.
But we appreciate it, Warlix.
I hope you guys like it too. But it's just a very little thing, actually. Yeah.
Hello, Noor. Haven't seen you for a while.
Hi, yes, I've been a bit away from all this of trying to job back in. So
Okay,
thank
you're
you
in Lahore, right? Pakistan still?
Is that yes, right now I'm in Lahore.
Okay, welcome.
Thank you.
Hi, Madia.
Hi, sir. How are you doing?
How are you?
I'm doing wonderful.
Yeah. We have met in Link possibly last time. Is it?
I've been following your program, sir. Lately, there were wonderful ideas, and also met you in Kuala Lumpur back in 2018 in WFNS.
Yeah. Possibly.
Exactly. All your wonderful initiatives and a lot of programs which are very informative. Being a resident, we used to follow your programs in our practice while we were where we have started our residency.
You're so welcome, Madia.
Thank you so much, sir.
Thank you.
Ike, do you want to talk about Quran before or after? Do you want to?
Well, maybe I can talk before.
Okay. Yeah, just take us on a little tour, you know.
You know what? I will do a program on this. I see that Professor Suresh Nair is also here. and so is
Oh, Remy's here. Remy's here too.
Vince.
Wow.
Hi,
Sir, good to see you,
hi,
sir.
how are you?
Sir?
Where are you right now?
I've joined, I'm in my farm in Nepal right now, but I have joined as the Director of Neurosciences at Karad, Krishna Institute, Karad.
This is close to Pune, eh?
Yeah, it's close to Pune. It's on the Western Ghats, and it's a very large hospital. So, and plus they are, we are starting a Neurosciences Institute, which is about 170 beds.
Okay.
And the neurologist who's probably going to join is Abraham Kurula, who's retired from Srijitra.
Yeah, very brilliant man, brilliant man. Oh, he's the best cat. Yeah, because he can look after your epilepsy and stroke both. Because he has both training in both these from US. He's one of the best actually in the country. So you have got the right person. Oh, we have got the right person. Yeah, very nice.
So much. Thank you.
Yeah,
I will talk to.
Okay. I am here. I will mute myself and I am listening to you. Okay.
Yes, sir. Yes, sir. Thank you, sir.
We haven't seen Remy for a while. Remy, hello. Remy,
Hey,
you
Remy.
there? Remy's in Mauritania or France, one of the two. You there, Remy? No. Remy, Clive, are you there? Perhaps not. Are you there, Remy? Yeah, we'll talk
John?
later. Yeah, we'll talk later, right? But I'd like to really meet the techs at the Karad, the technicians, the IT techs.
Yeah, sure. So,
because I can start broadcasting now just to practice, just to get, to get them used to what it is and how to set it. So just put me in touch with the IT department.
No, we're doing a world-class lab with the cadavers, exoscope, endoscope, and whatever is needed for a most modern lab. We're doing it. Manuel is coming to help us with all the simulations and stuff.
And maybe Warlocks too.
Yes, Warlocks will be in our team. Abida, of course, she's very close to him. She's in Mumbai. So Abida will be coming to help as well. And we're going to do at least once in a month. We're going to have an AV room just for neurosurgery TV. So we're going to relay all our dissections. We're going to have fellows, of course, coming in. So every month there'll be dissections, anastomosis sections, things like that. So we're going to do that, and we're going to be putting it up on neurosurgical TV. So of course I'll get you introduced to the techies, and let us see how we can take it forward.
Thank you, sir. It would be a great opportunity for us.
Yes.
Great opportunity.
Yes, it'll be the center of digital healthcare and neurosurgery.
Well, I won't say that there are really a lot of excellent centers in India, but as far as teaching is concerned, we believe that as much as you teach, as much as you can share, that is how much you will learn. So, this has been my experience. So we will try to share whatever we improvise, whatever we create, whatever we innovate. We'll try to share, and that's one way. Even criticism is a way that you can learn. Cystonostomy would not have been cystonostomy if it was not for all the critics. So, I am really thankful to all of the critics who made us to improve continuously. So, we will keep on sharing. We'll keep on putting our work in the world platform for people to see and criticize us or tell us some points which will be very helpful. So that's the only way we can improve.
Administration is behind the efforts to use digital means to spread education.
Yes, yes. See, this is the need of the hour. You see, young neurosurgeons in the last 4 years, I think they are getting nearer and nearer to good neurosurgery. Otherwise, they were all going away from neurosurgery by writing papers and not doing difficult surgeries, and this is a bad trend. So now, thanks to all this online education and sharing of surgeries, you see, we all have only one life. And for example, somebody like Dr. Suresh Nair, his experience, somebody will take one full life to get that kind of experience. So when he shares his experience, if you listen, then you understand that you are way ahead of what you would have done if you just did it things by yourself. So you have Sumit here, Binsu is here. So these are guys who can teach you one lifetime of experience. So this is, and when they share, we also learn from each other. So that's the thing. So the more you teach, the more you learn. That's the thing,
Mhm.
Sir, good evening, sir. Sumit, sir.
Hi.
Well, one
Hi.
minute.
How are you, sir?
I'm nice. I'm good. How are
Thank you,
you? Hi, bro. Hi.
Hey, Sumit.
Hi.
Thanks, man. Thanks for coming. Yeah.
Hi, my pleasure.
And I was telling them, the more we share, the more we learn. And, everybody has their own experience, and that experience is very unique. So
Correct.
your experience is very, very different from mine, very different from somebody else. And when we share, we go together to the forefront.
Correct.
So we advance together. That is the whole idea of teaching. That's the beauty of teaching.
Okay, 1 minute.
Yeah. I'm ready to start whenever you say, John.
Okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neuroanatomy TV, as well as Neurosurgical TV. We have the pleasure of having the mentor of Neurosurgical TV, Ike Cherian. I'll just turn right over to Ike. Welcome, Ike.
Well, John, thank you very much. I still remember about 4.5 years back when you were in Nepal and we were starting Neurosurgical TV. And I remember telling you that this would go a long way. And I'm proud the way that it has gone. And thanks to the corona pandemic, we have the world's best teachers all ready to share. I've been learning too from all of them, and whatever I can teach, whatever I can share, whatever little experience that I've had, I'm also very glad to share. So today we'll be talking about the surgical strategy of aneurysms. Now, I don't want to make it very complicated. The surgical strategies, any aneurysms, when you operate any aneurysm, as a youngster or as a middle skilled surgeon or a very high skilled surgeon or a master, there are a few things that doesn't change. So first thing that you have to understand is failure to prepare is preparation to fail. Remember that for aneurysm surgery. There will be no better scenario than an aneurysm surgery where if you go and not have a look at the angio properly, you're going to have a failure, how much ever good you are. You may get away with it. 50% of the time you may get away with it, but you really want, the first strategy that you would want to have is to visualize the aneurysm the way the patient is lying down on your table. So all you young guys out there, take the angio, don't just see the angio, imagine the IC, the A1, the different branches of MCA, the two P1s, the basilar artery, the superior cerebellar artery, the optic nerve, each structure, you imagine the way the patient is going to be positioned. And then you dive deep into that. If you dive deep into that, then you will understand how the aneurysm is going to be. And once you understand how the aneurysm is like, then clipping is going to be easy. You don't have to be rushing yourself. So before I talk about any surgical strategy, Dr. Nilange, I'm giving a talk, online talk. I'll call you later. So this is your main strategy. I'm sure all the masters here, Dr. Nair, Dr. Sumit, Binsu,
Yes, Yuha just arrived.
all of,
Yuha just arrived.
of course, Yuha, of course. I mean, he is the master of masters. So he will also tell you. I remember how when we were working in Biratnagar, how much time Yuha will spend with each scan, and that's after 5,000 aneurysms. I remember him putting the scan, you know, he would put the scans just in the way that the patient is positioned. So sometimes he'll put scans upside down and look at the aneurysm to see how the aneurysm is, and then it's easy, then it is fast. So I'm going to share today about the few other things that we will need to take care of when we show you cases, and then we will. So yes, so this is a basilar tip aneurysm. So you can see that that's a basilar tip, that's a basilar artery, that's two P1s. The superior cerebellars, barely you can see them, barely, very barely you can see them. And that's aneurysm. This aneurysm is posteriorly directed, and well, there are many ways to clip it. Of course, you can, experts like Yuha would do it subtemporal perhaps. I would always do it tyrional with a transcavernous to open up the temporal lobe. So there are many ways of doing it. Okay, there is a half and half technique of doing it. There is a pretemporal, intradural pretemporal mobilization, temporal mobilization, then doing it. Finally, at the end of the day, your strategy is to get good space between the optic and the carotid and the third nerve, so that you have corridors. That is your strategy. Next strategy is getting proximal control. You must be able, if there is a problem, you must be able to get proximal control. These are the two things that you have to keep in mind. And all your effort is to realize these strategies. So first you should have a strategy. Here your strategy is to get good space in the opticocarotid space, and then good space in the between the carotid and the third nerve. So we are going now. So for that, first thing we are doing is doing an anterior clinoidectomy. So the clinoidectomy is being done, and after that, once you do the clinoidectomy, this is an aneurysm which is bled. So you can see that's a third nerve, that's a carotid, that's a PCOM. So you are opening the membrane of Lilliquist. This is the carotico-oculomotor window, and now I'm going back to the opticocarotid window. So I'm opening the opticocarotid window. So also these windows, both these windows can be widened by opening a little bit of the proximal sylvian. Now, you don't need to open up the entire sylvian in a basilar tip. If you've seen the scan, so you need to know only what is necessary, whatever is necessary. So that's a carotid. That's a carotid. The third nerve is lateral. The carotico-oculomotor window is opened. Now the opticocarotid window is full of blood. So we are opening the membrane of Lilliquist there. And then we can see the basilar complex there. We don't know what is what, now your strategy is to identify the P1. So to identify the P1, how do you identify the P1? Your strategy is that you should see the contralateral third nerve. If you see the contralateral third nerve, that white structure is a contralateral third nerve. That one is a contralateral third nerve. If you see the third nerve, then you know that the P1 is above it. So that is P1. This is P1. That's basilar. So you saw the contralateral P1 there. You know that your aneurysm is here. That's your aneurysm. So it's a ruptured aneurysm. So you're keeping a patio over it and slowly dissecting. This aneurysm is directed towards this P1 and posteriorly. So now I'll have to do a neck dissection of the aneurysm and make sure that I get space between the aneurysm and the P1. That's what I'm doing right now. So this has to be a very, very, so if you have a strategy, you realize your strategy with patience. You really don't, you really don't go after it. Today we were doing some mountain trails, hill trails near the farm. So, there were people who were very inexperienced and they were slipping. That's because they are looking not just at the next step, they are looking few steps ahead. This is something that you must avoid. You must look only at the next step. And when you're looking at the next step, things become very easy. If there is a small arachnoid strand, look at taking that arachnoid strand off, not at clipping the aneurysm. That will come. So you keep on separating with patience, keep on separating arachnoid strands, keep on making space. And once you have achieved, you can go ahead and put in your clip. Now, this is all very unsettling for the beginners. Believe me, we also had times when, when we were very unsettled. Your first basilar clip is not easy. I can assure you that. All the masters will assure you that. Don't think that when we are clipping right now, don't think that we didn't have our moments of trials and tribulations and problems. Don't think that all our basilar tip patients woke up without any problems. Okay. We all had so many failures, and that is what we learned from that. Okay. So this is how you learn. This is how you slowly grow. So that is the basilar tip clipped. And then now you examine for perforators, you examine for both the P1s. The superior cerebellars, the interpedunculair fossa can be seen. Basilar is an aneurysm. Basilar aneurysm is a surgery where I wish I could show it to you in 3D. You need to see it because the interpeduncular fossa is in 3D. It's not in 2D. This is something that you need to see because you need to see the edge of your clip behind the aneurysm. Otherwise, if you put it, sometimes if the aneurysm ruptures, this is one of the most treacherous situations. You don't want to half clip the aneurysm and rupture the aneurysm. Okay. So this is something that you have to be very careful of. Right. So now we are going into a transitional type of aneurysm. You can see that in this aneurysm, you can see that the aneurysm is here. That's the clinoid process. So the aneurysm is here. So you need to remove the clinoid process and get this aneurysm neck. That is the C3 aneurysm, C3 part of the carotid going down. That's the C2 part of the carotid, and that is the C4. So you have C4, C2, C3. Like that, you can see that this is the aneurysm. That is the C3 part of the aneurysm. This is the aneurysm. See? So this is not an easy aneurysm. It's a transitional type of aneurysm. So you need to take out the clinoid process. So how do you take the clinoid process out? You do a sagittal and axial unlocking. Okay. So for doing a sagittal and axial unlocking, you need to do a transcavernous dissection. Pericavernous. What I do is a pericavernous. You use a diamond knife and then you cut the orbitomeningeal band. That's a cavernous sinus. So you are separating the temporal lobe dura from the true cavernous membrane. So that is what you're doing. And you keep on doing that so that you open up. This is called the axial unlocking. The temporal lobe is being unlocked from the cavernous sinus. Okay. Once you do that, your anterior clinoid process will be pretty easy to remove. So that is your anterior clinoid process there. That's a cavernous sinus going into the superior orbital fissure. So the cavernous sinus is exposed only till it's required. And this is not a cavern, this is not a external, this is not an anterior clinoid that you can remove with a ronger. You should never do that. That will be suicide, because this aneurysm is ruptured aneurysm. And this aneurysm is the only difference between the only thing that separates you from the aneurysm is a thin layer of dura. So you don't want to take out this anterior clinoid process with a ronger like I did last time. So I'm going to drill this anterior clinoid off with a 2 millimeter drill first, and then with a 1 millimeter drill. So that is the optic nerve. This line is the optic nerve. That is the clinoid process, and that will be the strut. We have to remove all this bone. So our strategy is to remove all this bone, every single piece of bone there, so that when I open intradurally, I can easily cut all the ligaments. I can mobilize everything, and I can clip this aneurysm without much effort. So when you are drilling above the optic nerve, that is the optic nerve. You must remember that's the extradural optic nerve. Sorry. So we are going ahead and drilling the clinoid, extradural drilling of the clinoid. So that's the transitional aneurysm just behind you. So you have to be very careful. This is you have to use the drill like a paintbrush. Okay, not you cannot use any force here. The extradural drilling of clinoid is you must understand there's no control here. If the aneurysm ruptures, you fry. By the time you open up your dura, things are going to be, not very pleasant. Okay, so I'm going to eggshell it, and then leave that bone there. Okay, so then that is the lateralmost margin of your clinoid. Then you have the optic nerve in this side. Then you have the strut there. So I'm going to eggshell all this bone. That's the optic nerve, and that's a strut. So you have to remove the strut with a 1 millimeter drill bit. Okay, so all this bone is eggshelled and left there, so that I can raise it away with a dissector very, very carefully. So this part is the optic strut. You remember, this is the anatomy. This is the optic nerve, and there is the carotid and the aneurysm. Okay, this is optic nerve extradurally, and that is the optic that is the carotid and the aneurysm. So we are going to drill that part now. We're going to look at the thickness by just putting in a little bit of dissector there. Optic nerve can be medialized a little bit, so that's a falciform ligament will come there. Once you cut this intradurally, you'll easily be able to mobilize the optic nerve, and the carotid, the distal dural ring extending here can be cut. So that is a 1 millimeter drill. You are going to use 2 millimeter and a 1 millimeter drill to take out your optic strut. So that's the optic nerve and carotid margin. That's the carotid, and that's the dura. And underneath the dura is your aneurysm. It's a ruptured aneurysm. So you can see that's the dura. That's the optic nerve. And I am now using a 1 millimeter drill. That's a 1 millimeter. It's like a needle. Under very high magnification, you can see the suction and the drill. It's like a needle. It can easily go through the dura. I mean, if you are careless, if you are not under very high magnification, I thought I was doing surgery under high magnification, but when Yuha came, I understood that I have to increase it much further. So now we do under very high magnification. So that we are eggshelling off the strut, and you can see the dura there and the aneurysm there. We are still going ahead, and one of the secrets that we use is that we don't use a fresh drill, 1 millimeter drill. We use a 1 millimeter drill that has been used a bit. Okay, that doesn't go through so easily. And also, I always balance my drill. Somebody will be holding my drill so that the weight of the drill is not on my hand. Okay, these are two important things when you're using a drill, because at this kind of fine drilling, this PCP drilling, etc., you don't want the weight of the drill on your hand. So we keep on drilling, and then keep on eggshelling and keep on removing. Now we are opening the dura. We open the dura now. We release the arachnoid. And you can see the aneurysm right there. That is the aneurysm. So we go to the opposite side, remove all the blood. So you can see the optic nerve there, and that's the aneurysm, and I'm cutting the falciform ligament there. It's very easy because there's no clinoid. There's no drilling required at all. This is the aneurysm. Now the optic strut, the clinoid, the optic roof, everything is gone. So I just have to cut the falciform ligament and then cut the proximal dural ring, and I have very good control of the neck control. And if there is a neck control, if this aneurysm bleeds, it's an advantage, because then you don't have to waste time in dissections. You can aggressively go for a clipping. But if you don't have neck control, well, it is a bit of an issue. So dissecting the proximal, that's the optic nerve, that's the aneurysm. And now you have to see the carotid. And after seeing the carotid, it's rather easy to clip this off parallel to the carotid. That's what you have to do. You have to be going parallel to the carotid. So now you see, I am demonstrating to my residents the line of the carotid and the line of your clip. So of course you have to see the carotid first. I mean, yeah, that is what we are doing right now. We are just displacing the aneurysm and showing where the carotid is. I could cut a little bit more of the falciform ligament medially and mobilize this optic nerve further, but there is no need. I'm seeing the carotid beautifully here. That's a carotid here, and that's a carotid proximally. So the aneurysm is here. That is a carotid distally. That's the carotid proximally. So once I see that, then now I know where this aneurysm is arising from. Then it's rather straightforward, these aneurysms. If you don't expose properly, these aneurysms can be a pain in the neck, believe me. If you clip, you can clip the carotid. So now you can see the carotid. Once you are displacing the optic nerve a little bit, you can see the carotid there. That is the carotid there. And you can see the origin of the aneurysm. You take your time, that's the whole secret. That's a carotid. So you know what is the line of this aneurysm, and then you put a straight clip parallel to the carotid. Okay. And you put a straight clip parallel to the carotid, and things are good. And if you cannot get it with one straight clip, and you should never foray into the carotid line, you should always be parallel to the carotid line. Sometimes you cannot get things with one straight clip. So what you do is you put another clip. Okay, that you can see the carotid going down, the cavernous carotid, the transitional carotid cave going down there. So there is a little bit of an aneurysm left here. So that's the line of the carotid. This is the line of the carotid. So you need to be parallel to the line of the carotid. So another clip, you can always put another clip, not that big clip, but sometimes clips are not available. So you half clip it, you clip it, and with a larger clip. Now we have another case where you have one ACOM and another PCOM aneurysm. So this is not, sorry, this is not an ACOM, this is an IC bifurcation aneurysm. So it's a bit uncharacteristic. That is the A1 there, the MCA is here, and this is the aneurysm. So this is unruptured. The ruptured aneurysm is the PCOM. So I will do a tailored intradural anterior clinoidectomy. I don't need to do an extradural complete anterior clinoidectomy here. So I will do this is the anterior clinoid here. So once I clip this aneurysm, that is the unruptured aneurysm, then I can go ahead and look at the ruptured aneurysm. Now the strategy is always that when you are clipping multiple aneurysm, the first clip should not come in your way. That is the only thing. People ask which aneurysm to clip, ruptured or unruptured. It is not by ruptured and unruptured. It is by the fact that when you're putting in a clip, don't let that clip come in your way. Okay? And if you can secure an aneurysm before the other aneurysm, fantastic. Because you don't want your suction to touch this aneurysm and rupture it while you are exposing it. Okay? And this clip is not going to come in my way. So it is very simple. Now I have done a tailored anterior clinoidectomy that you can see, very simple anterior clinoidectomy. That's a carotid, that's a ruptured aneurysm, PCOM. Now the PCOM takes off, straight and into this triangle. So there is no way, if you put in a straight clip slightly curved away from the carotid, there is no way you can catch the PCOM. So of course, you have to look for the PCOM with the ICG after that. Sometimes PCOM is always, PCOM can be, doesn't have to follow a very, very strict way of anatomy. So you have to look at it. Now, the next is, this is an anterior choroidal artery aneurysm. Okay. Here the strategy is based on the fact that this artery goes like that, and unlike the PCOM, it just curves this way. Okay, it curves this way. So you need to know about that. So if you don't know about that, and if you put a straight clip like in PCOM, you're going to be in trouble. All right, half of the aneurysm won't be clipped. So you have to be parallel. You have to be parallel to the anterior choroidal. So that's what you're going to do. You're putting a curved clip there, and you are going to close that curved clip parallel to the anterior choroidal. And you should not catch the anterior choroidal when you're doing it. And that's it. Now you will see the anterior choroidal artery curving into that region. That's anterior choroidal artery curving into that region, and that's the aneurysm which is clipped. Right. So the next, and that's the patient. Okay. So the next is a blister. Now, Chanu, can you keep quiet? I'm having a talk. Now this is a blister. So we are first getting ready for a insurance bypass. So a blister clipping is always an issue. So you can take a little bit of normal wall. People say you have to trap and bypass. So this is not always the case. Okay, yeah, people, you have to think, you have to understand that you have to make things. So what you can do is, that's a carotid there, and that's a blister which is attached to the frontal lobe. Okay, you have the third nerve there. So the blister is attached to the frontal lobe. You don't want to rupture that part. So that is a proximal carotid. That's a proximal carotid. And you can see that this is the blister. So therefore, you're going to clip the blister. Okay. Now clipping, that's the line that you want to clip the blister. Now you can see the abnormal wall, and you have to, when you are clipping a blister, the problem is the blister can just, it can tear. So I'm going to show you something that I know by premonition. I don't know, probably some sixth sense. I already knew that this is going to rupture. I don't know why, but I can tell you, sorry. So let us go back a little bit. Yes. So I'm going to put in this clip and see that's what happened. Okay. So we got the chaotic control and then we clipped, and this is another mistake. Okay. This we didn't see that a small patty strand was onto this thing, and after clipping, the patty was taken out, and this is what happened. So we immediately got it under control with two clips. I mean, two suctions, and then we put in a curved clip, and we looked at the ICG as well as the flow 800. This had excellent flow. I think we have the flow 800 picture as well as the ICG picture. So it shows excellent filling, and there's absolutely no problem if we take this much wall. Please understand that 80% of the wall is available for you. So this part is the abnormal wall. So you can take a little bit of normal wall along with it, and this is the way to clip the blister if you are clipping it. Of course, trapping and bypassing is another way to do it, but you really don't need to complicate things all the time. Okay, if you can do something in a simple way, it's always better to be done in a simple way. And the last case we have is the case of DACA. You can see that this DACA is projecting to the other side. Okay, it's just projecting to the other side. So we go from the other side. Okay, this maybe it is that the what people might say is that you don't have any proximal control. Yes, that's true, but well, you see the aneurysm, you can always clip it. You can cut the forks and get into the opposite side if you need, if things are not under control. And here we have absolutely no retraction. Okay, absolutely no retraction, and we are making space around the aneurysm by putting Surgicel, pushing Surgicel and gel foam around it. This expands the space. We don't put any retractors. We put patties between, a roll of patties between the brain and the forks, and between the aneurysm, on both sides of the aneurysm, we put Surgicels and gel foams, and slowly make space. Okay, so this is a very elegant way of clipping, because you are not using a large retractor to I'm not saying that using a retractor is harmful or something, but in some places, maybe when you can afford to do it, better to always, this is a journey. When you think retractors are necessary, you don't make it into a dogma that no retractors, not like that. So when you think retractors are not necessary and you need to push your skill, then you can go ahead and do that. So keep on advancing that Surgicel and gel foam around the aneurysm and making space. Keep on making space so that for your clip, when your clip is opening, that you see the amount of space that you have between the brain and the forks is really minimal, very minimal. So you just have enough space for the clip to go in. That's it. And you are using that clip applicator to retract that brain gently, and then you're putting the clip in. You're coming from the opposite side and clipping that aneurysm off. Okay, right. So now you can see that that area is collapsed. So you now only have the space for that clip. So that's about it. And I hope instead of talking too much, if you show videos, then you start understanding things better. So, but we have a lot of masters here, and I think we can stop sharing, and we can ask and discussions from these masters who are present. So maybe I'll ask Yuha, Binsu, Sumit, Professor Nair, all of you to comment and also talk about their experiences. I mean, I'm sure many other senior people are here, and I would also ask them to. Yuha, first I will ask Yuha to comment.
Hey, the Kundugi. Wait.
Yuha, are you there?
Yuha?
I'm here, yeah.
Okay.
Okay, it was nice talk. Thank you very much, Jaip. So I have too many stories, so I don't want to make a long discussion. I've clipped my first aneurysm 1976, and I have done after that more than 6,000 aneurysms. I am using extremely much temporary clips and also adenosine to help the clipping, and this is maybe the difference what I saw here. I wouldn't clip basilar tip aneurysm without temporary clip on the basilar artery, and then I wouldn't speak never about something that is very easy. It is never very easy. I think it is the question of attitude. Very easy aneurysm can turn to disaster during the surgery, and so if it is very important to take the serious attitude against very simple looking aneurysms. But otherwise, I liked the videos and the discussion, and I have not much to add to the techniques. But temporary clips I'm using a lot. So this makes like my teacher, late Dr. Drake said, it makes another surgery even a pleasant one. So these are my additions. Okay, nice talk. Thank you very much.
Thank you, Yuha. Thank you so much. Binsu is here. So Binsu, your comments, please.
Very nice talk. Yep. How many aneurysms did you clip in your career by now?
Is about is 600 plus, about 600 plus aneurysms. I am nowhere near the experience of Yuha or anybody, but in the last 13, 14 years, I have been in a country where absolutely no coiling is there. So we clip everything. So around 600 plus.
Okay, great. Nice talk.
Thank you.
Thank you. I'll ask Professor Suresh Nair.
Yeah, I am audible to you, no?
Yes.
Am I audible? Yeah.
Can you move your head? You're not in the camera. We're just seeing your chin. There you go.
Is it okay now?
Yes.
Yeah.
Okay. Okay, I am not seeing my face anyway. It's an excellent talk. I learned a lot. You know, I am a tumor surgeon, but still I keep on listening to all the talks. I think I'll put it in a nutshell what you have told. You showed first video clippings of very difficult basilar aneurysm, top aneurysms. Then we switched over to transitional and proximal ophthalmic segment aneurysms. And later you wrapped up with showing some anterior circulation aneurysms. But what I learned and what you also teach everybody is when we go from a therional route, say the structure which obstructs a surgeon to the intrapedunculair fossa is the carotid artery. So unless you mobilize the carotid artery medially, you cannot get into the intrapedunculair fossa or to the basilar top or that. You correctly showed that, you know, we have to unlock, axial unlocking by cutting the superior meningo-orbital band, unlocking the superior orbital fissure by cutting the meningo-orbital band, then taking the dura propria of the true cavernous membrane, unroofing the optic canal, then doing an anterior clinoidectomy, then come intradurally, open the falciform fold, dural ring and then go and clip the aneurysm. So what the point is, tumor gives you space. You don't have to do many a time all this thing, because you get opticocarotid space. It's a carotid and lateral to the carotid. All space may get opened up, and then you can follow that space. But for a vascular lesion, you have to create a space. So how we create a space is mobilizing the internal carotid artery medially. How we mobilize it medially? You cannot mobilize it medially unless we do all the steps we demonstrated. Most important is unroofing the optic canal, cutting the falciform fold. By this, you can mobilize the carotid artery medially. Then once you mobilize, you can mobilize the optic nerve. Once you mobilize the optic nerve, you can mobilize the internal carotid artery and open up the whole area. And it was excellent lecture. I learned a lot from you, and I keep on learning from you. Thank you. Keep it up.
So, of course, I must say that sir was my examiner, and of course, we have learned so much from you. Thank you so much, sir.
Thank you.
And Professor Sumit, would you say something?
Yeah, hi. As usual,
Sumit,
a wonderful presentation. Can you hear me? Can you hear me?
Yeah. Yes.
Okay. So as usual, a wonderful, awesome teaching exercise. I mean, it's a wonderful pleasure to always see you operating. And it is said that, I mean, if you see anyone operating, and if you feel that it's being wonderful and so easy that you can do it, it means that the surgeon is doing is very good. So I mean, this applies up equally applicable to you. So a couple of quick points. I mean, especially I just saw your 4-5 aneurysms that you showed. In fact, and I was quite surprised and happy also that you did not use temporary clips anywhere at all in your entire surgery, as pointed out by Uyuha also, which is quite a bit of difference from my experience as far as I have been doing. I mean, it's awesome to clip without temporary clipping as much as possible. I know that, but I mean, my particular practice is to secure an aneurysm, especially if a basilar aneurysm, if you are operating, it takes a lion's heart to clip that basilar aneurysms without applying a temporary clip. So I use that temporary clips. I mean, I can say in ruptured aneurysms only, of course, and that about 80 to 85% of my clippings are after the temporary clipping. It gives you a false or maybe a correct sense of security while you apply a position the clip, especially in complex aneurysms, especially in MCA aneurysms, which are to be morphologically reconstructed. And one particular point, I mean, about the bleb aneurysms, I mean, these are very treacherous aneurysms which are prone to rupture because of a defect in the wall, in the vessel wall. And I mean, it's very problematic sometimes to deal with these aneurysms. So clipping them without temporary clip, and that too with this, can take you in a problematic situation. And one particular clip reconstruction is available for these bleb type of aneurysms, which is a shunt clip. I mean, if you cannot clip it directly, then what happens is that this is a special type of clip. We all are aware about it. And I have an experience of one such being clipped by means of a shunt clip. We applied a gel foam and around that clip, and then encircled the internal carotid artery entirely over that small tiny bleb aneurysms. These are very treacherous aneurysms, as we all cannot agree more, and have to be dealt with by these type of clips in a beautiful manner. So excellent surgery. I have an excellent teaching lecture again, and I congratulate you for your 600 plus aneurysms.
Thank you so much, Sumit. And Yuha, since you put up this temporary clipping issues, see, we use adenosine. So as Yuha was saying, we use a lot of adenosine. So when we have any problems, adenosine really helps us. So, and in this really narrow space to put in a temporary clip, sometimes I have seen Yuha doing it very easily. But when I put in a temporary clip, one of the problems that I have is that to maneuver another clip into the space is sometimes a bit difficult. But of course, if I go transcavernous, if I do the complete transcavernous route, I open up the entire third nerve along the cavernous route, then it becomes very easy. You have so much of space. And we used to earlier drill the PCP so that we increase the space as well. So there are many maneuvers to increase the space and put in a temporary clip and then of course clip the aneurysm. But these days when we see that the neck is strong and of course it is not easy at all. I am not saying it's easy at all. We have had disasters with aneurysm, basilar tip aneurysms. But right now what we use is we use adenosine and then we try and dissect and then we bring down the BP and during that time we clip it. This is what we do generally. So of course, if there is a difficult scenario, I still use the temporary clip, but most of the time in basilars, I clip without temporary.
Okay. Great. There's a couple of questions in the panel if you want to look at them.
Yes.
Yeah, well, there's one question from Hitesh Kumar. Is the length of the clip important? And any problems due to a longer clip?
Yeah, see, this matters only when you have a lot of clips. Like, for example, after Yuha came to Biratnagar, we had about 100 clips. He donated that and went. So Professor Carter, when she comes down, we have a lot of clips. But otherwise, when I started aneurysm surgery, we had only 4 clips. So whatever the length of the clip, you have to clip it with whatever clip is available. So, but then there are ways to get around it. It may not be very elegant, but there are ways to get around it. So don't worry about the clip length and things like that. Always be creative so that, if it's a 10 millimeter clip, you can have the clip standing out. Of course, you don't want to stand it out, you don't want it to stand out of your head. I mean, you don't want to stand out. I mean, you don't want it to stand it out of your brain. This is not good. For example, you are clipping an MC aneurysm and you are keeping a huge clip so that you can't put the bone flap back. That's not okay. But if you are creative, generally you can use many various clip lengths. You remember Sano, he used to drill off the clips. He was a perfectionist, so he used to drill off the clip length. Whatever length is not necessary, he used to drill it off. But this, you have to, after drilling it off, you have to make sure it is not sharp, because then you can create other problems. So clip length is not exactly the first thing that you have to worry about. You have to, ideally you should have calculated what is the clip length based on your CT. Okay, based on your CT and the neck of the aneurysm, you should have calculated the clip length, and that is the clip length that you ask for. But when you ask for it and then you don't have a clip length anywhere near that, you have to clip with whatever is available. Okay, don't take that as an excuse not to clip the aneurysm.
There is one rule. So the clip length should be 1.5 times the base of the aneurysms. This is the proper clip. This is coming from geometry. 1.5 times. So 6 millimeter aneurysm needs 9 millimeter clip and so on. This is the exact clip. But of course, if you don't have all lengths, then you have to use all kind of clips. But it is easy to drill the long clip shorter, but of course, short clip you cannot make longer.
Okay, Thomas Block asks, is a pilot clip a solution to BA aneurysms?
Never use the pilot clip. I don't know whether it's a solution to basilar tip. Basically, what it means is clip the aneurysm in half, and after that, go on dissection so that you make sure that things are not ruptured. But you must understand that the entire aneurysm wall the neck is strong, but the aneurysm wall may not be very strong. So when you clip an aneurysm in half, you may be, there is a chance that you may be, and when you move that clip around, there is a chance that you may tear it. So you really don't want, and especially in the basilar, you really don't want to do that. Okay, so dissection is the key rather than pilot clip. Pilot clip is, a sudden solution, and then you can dissect. But rather than that, don't disturb the dome. Keep on dissecting. Keep on dissecting the P1. Keep on dissecting the neck. Keep on dissecting the perforators. And then at the end of it, if you want to mobilize the dome or something, then you can put a clip, not a perfect clip on the neck, but slightly further above. And then you can mobilize. But before dissection, no pilot clip. So the solution to basilar clipping is good corridor, good dissection. Not actually, pilot clip cannot be a solution to basilar clipping.
Okay, Thang Kor Kai asks, is there any compression and resulting neural deficits by the placement of the clip by any chance? And like, for example, to the third nerve.
Well, never seen that. Never seen that complication. Of course, I mean, if you are doing an aneurysm, you have to be very careful about and very careful and aware about each of these structures. And you have to be cognizant of each things around you. So, and you're going to be very gentle. So it's hardly that you create third. When you're going transcavernous, when you're mobilizing the third nerve, yes, you can have a partial third nerve paresis sometimes, which often resolves, but that's when you're going full transcavernous. But otherwise, half transcavernous approaches like this, where you're doing only the cavernous peeling and then going intradural, hardly there is any chance of third nerve getting damaged. And clip placement, I've never seen it.
Okay, Kumar Abhinoff asks, is ICG monitoring useful for such aneurysms?
Of course, yes. Very useful.
Okay.
Yeah, very useful.
Hello, sir. Can I ask you a question, sir?
Of course.
Please.
Sir, I'm Dr. Shahnawaz. I'm a resident from Bangladesh, sir.
Welcome.
Sir,
Yes.
what are the points do you consider from the DSA or 3D DSA when the height of the bifurcation of the basilar artery varies? I mean, the surgical approaches, to choose the surgical approaches according to different variation of the height of the basilar tip aneurysm. So what are the points do you consider regarding selecting the proper approach?
Yeah. See, you need to see where is the PCP and the bone, the dorsum sellae, the posterior part of the dorsum sellae, and the PCP. You need to see that with the base of the aneurysm. That is number one. That is the main thing that you're wondering about. Now, if you can have high riding aneurysms, you can have normal aneurysms, and you can have low aneurysms. Now, normal aneurysms you don't need to do any extra maneuvers. You can do by a simple pterional Transylvian technique. I wouldn't use simple, but I'm saying you don't need an FOZ and all these fancy approaches. So, but if it is a low lying, if it's a high lying aneurysms, to get that higher elevation, you might, I don't do an FOZ. What I do is I cut the zygoma and I take down the muscle all the way down and I drill the temporal fossa so that I get that elevation. And if I need to go down, I drill the PCP off. So once you drill the PCP off, you can get into a low-lying aneurysm. So these are the changes that you have to make for this kind of an aneurysm. For a subtemporal route, it's different, completely different. And that maybe Yuha can tell you as to what are the maneuvers that you maybe, there may be times when you may have to put a stitch on the tendon or maybe cut the tendon and get proximal control.
Okay, Kumar Abhinoff. Oh, I'm sorry. Kumar Abhinoff asks, should the craniotomy approach change as per the dome or base?
Well, the craniotomy doesn't change per se, but you can add things to the craniotomy. Like if you need a zygomatic clip, if you take off the zygoma, then you can get more elevation. So the craniotomy per se doesn't change, but you're adding things to, or you're removing more bone in certain areas to get certain windows. So that's it. Otherwise, the craniotomy as per se doesn't change.
Okay, Hitesh Kumar asks, can you take non-fetal PCOM and clip in PCOM aneurysms if the origin of the PCOM is not obvious?
No, you don't want to take any part of PCOM in a PCOM aneurysm. Okay, a non-fetal or fetal, whatever, you really don't. I mean, in a PCOM aneurysm, you are not supposed to take the PCOM in a clip. If you're taking the PCOM in a clip, that well, in a life-saving situation, when you have a rupture and you have severe bleeding and severe swelling, it is excusable to take the PCOM in the clip. But otherwise, I don't think you should know that the PCOM actually goes medially. So unless you're putting in a clip directed towards the PCOM, it's very highly unlikely that you're putting in you blocking the PCOM off. If you're going parallel to the carotid, there is very low chances that you're taking the PCOM. I mean, you're taking the PCOM, but most often the artery that you will take is the anterior choroidal. So it is, I mean, when you are aneurysm surgeons, don't take PCOM in your clip. Okay, fetal PCOM or whatever PCOM it is, don't take it. Okay, you should see the PCOM. After you clip, you should examine it in the opticocarotid window and look at the ICG, how the PCOM is feeling. And if there is a doubt, just direct the clip a little bit more laterally, just move it a little bit more laterally, and so that you can see the PCOM origin.
Very good. Okay, more comments or questions from the panelists? Okay, that was a great webcast. a lot of opinions. And I'd like to thank you, Ike, and thank all the panelists for coming out. And did you want to take us on a tour of Karad, where you're going next?
Yeah, so I can tell you a brief about it, maybe 1 minute. So
okay,
this is the beautiful place in the Western Ghats. Western Ghats are the mountain ranges in southern India. So the altitude is about 600 meters, full of forests, rivers, and amazing climate. So quite different from Biratnagar. Now, the second thing is the hospital per se is one of the largest hospitals that I have seen. It's almost 100-acre campus, and they've got literally everything. So it's a trust hospital, charitable hospital. So they've been doing a great work. They have all the specialties, super specialties, everything, and they have almost 250 medical student intake. They have they have auditoriums. That is what I was looking for. They have auditoriums of 1,000 seating capacity, 500 seating capacity. We can do any conferences there. And we are building a 170 beds neurosciences institute with everything, intraop, CT, navigation, exoscope, whatever you can think of. So, and plus with neurology, one of Dr. Nai was telling, one of the most brilliant neurologists also is joining us. So we already have the MCH program. We're starting the fellowship program. We're transferring everything from Biratnagar. And you can be sure that if any one of you wants to come down to Karat, you will be our host. You will enjoy the beautiful place. And I hope we can show you some beautiful surgeries as well.
Okay, we look forward to that. And we'll end this broadcast. And thanks everybody for coming. We'll see you next Monday.
Thank you so much. Thank you guys. Yeah, see you guys. See you. Thank you, Juha.